I think we're going to go ahead and get started. This being Washington, we'll have people continue to trickle in, but you all get gold stars for being here on time. We'll get started so as not to penalize you. I'm Bob Hathaway. I have the good fortune of directing the Asia program here at the Wilson Center. And in the absence of several of my colleagues who have been more directly associated with the organization of this conference, they enlisted me to welcome you, which I'm delighted to do. Unfortunately, I've not yet discovered how to be in two places simultaneously, and since I did have another 3 o'clock engagement, I'm going to have to run off. But not without, first of all, saying we're delighted to have you here. We're delighted as well to have many people, we trust, from around the world watching this via the wonders of webcast. No doubt most of you in this room know something about the Woodrow Wilson Center, but since not necessarily everyone outside of Washington does, if you in the room will simply humor me for 30 seconds while I say a bit of a commercial about the Wilson Center. We are the nation's memorial, official memorial to the country's 28th president. Woodrow Wilson was a scholar long before he was a politician or a statesman. The Wilson Center seeks to serve as a bridge between the world of the scholar and of the policymaker, and to commemorate both the scholarly depth and the public policy concerns of President Wilson. I think our program here today is a perfect example of how we seek to straddle both those worlds. This program this afternoon is a joint enterprise both within the Wilson Center and between the Wilson Center and outside the institution. Within the Wilson Center, it is a collaborative effort by our Environmental Change and Security Program, our Global Health Initiative, and our Africa Program. We are delighted to be partnering today with the Center for Development and Population Activities. I am going to vacate the podium at about 15 seconds to the President and CEO of the Center for Development and Population, Carol Peasley. Carol has a distinguished career with USAID, where she served in, among other places, several places in Africa as well as in Russia. Carol, we are delighted to be working with you and your organization. You do us honor by collaborating with us, and welcome to the center. Hope you have a good program, and now I'll turn things over to you.
Thanks very much. Thank you very much, Bob, and we do appreciate you coming in. We know how busy you are, so thank you very much. As Bob said, I am Carol Peasley, the President and CEO of CEDPA, the Center for Development and Population Activities. And again, I'd like to echo Bob's thanks to all of you for taking the time to join us for this important discussion this afternoon. We will shortly have a very interesting panel discussion, but before we begin, I would like to take a moment to thank the David and Lucille Packard Foundation for their generous support, which has enabled CEDPA to conduct an exciting Reproductive Health Champions workshop here in Washington, D.C. over the past 2 weeks. Two of our participants from the workshop are with us on the panel today, and I will say more about them in a few minutes, along with our very distinguished panelist, Dr. Nafis Sadegh. I'd also, again, like to thank the Woodrow Wilson Center for kindly co-hosting us today. We are very honored by our partnership with you. Before introducing our panelists and beginning the discussion, I would like to just offer a couple of thoughts as a backdrop to the discussion. As those of us who live in Washington, D.C. know all too well, international family planning and reproductive health have far too often become a partisan political football used to score very cheap political points. And we also all know that this should not be the case, that there's a lot of irrationality to some of this rhetoric. We also know that most Americans do care about the rest of the world and do want to save people from dying needlessly. And most of those same Americans also know that strong family planning and reproductive health services saves lives. And those facts are very, very clear. And they were laid out, I think, exceptionally well in a report that I hope all of you have seen that was released earlier this year by the Council on Foreign Relations. And I'm just going to repeat 3 of those, I think, very essential facts that I hope the American public can better understand. First, that the health, security, and well-being of families depends importantly on the health of women. And secondly, that when women have the ability to voluntarily space and limit the number of children they have, maternal, newborn, and child deaths decrease, as do abortions and abortion-related injuries. Those are facts. And thirdly, that some 215 million women in union and of reproductive age globally want to avoid pregnancy, but their needs are not being met. And the largest unmet needs for women are in Southern Asia and Sub-Saharan Africa. And again, these are facts. But as clear as that evidence is, the message is still not getting through to too many people. We are therefore here today to help strengthen that message. And I think we in this room all know that the voices of women champions may in fact be the best way to influence policymakers and just average citizens around the world, and that the voices of these women champions can help people better understand the importance of investing in international family planning. Today you will hear from 3 dynamic women champions, 2 of whom are participating in the SEDPA advocacy workshop, Tigas Kasa Milko from Ethiopia and Rosemary Ardefio of Ghana. And they will share their experiences and highlight why investing in family planning and reproductive health services in their countries is so important. But I want to emphasize that they are just 2 of 24 spectacular participants who have been here with us in this workshop, funded by the Packard Foundation. Their fellow participants hail from Ethiopia and Ghana, as well as Kenya, Malawi, and Tanzania. And unfortunately, time does not allow to have all 24 of these wonderful women speak, but we will have a question and answer period. And I would encourage you, if you have questions, not just to the panelists, but any of these wonderful women here in the front rows. And I think during that question and answer period and subsequently in the reception, I think you will be as impressed as I have been over the past 2 weeks by these really very remarkable women. I'd also like to take advantage of the opportunity to introduce another very old friend of SEDPA who's here with us today, Ousmane Traore from Mali. He is a SEDPA alum from the early 1990s and the executive director of ASDAP in Mali, a long-time partner of SEDPA. And if you have any questions for Ousmane, I'm sure he'll be happy to answer them as well. But first, it really is my tremendous honor to introduce one of the most important champions in the reproductive health field, Dr. Nafis Sadik. As most of you know, she is the special advisor to the UN Secretary General Ban Ki-moon and his special envoy for HIV/AIDS in Asia. A pioneer, she was the first woman to head a UN-funded voluntary agency, and she was the executive director of UNFPA for 14 years. And I would hazard to say that she is probably the single most important reason for the ICPD program of action that was agreed upon in Cairo in 1994. She is a force. And Dr. Sadiq was trained as an OBGYN and has dedicated her career to women's health and family planning. Please help me in welcoming her.
Thank you very much, Carol, for that wonderful introduction. I'm always worried that that I hope I live up to that and those kinds of introductions. Anyway, I'm very happy to be here and to speak with all of you assembled here. And I'm also delighted to see so many old friends and to greet all our very young colleagues and champions. I think the world today, more than ever, needs champions like all of you. SEDPA and I go back a long way. Ever since SEDPA was founded in 1975 by an old friend of mine, Kanwal Gulhati, I've been associated with it. It was formed during the first year of the first World Conference on Women. I think we have all gone together very much forward since then. In 1994, at the ICPD, which Carol refers to, and when we held the International Conference on Population and Development, SEDPA played a critical role in making the NGO participation a very, very essential part of that conference. And as some of you, if you know the history of the conference, I think the NGOs were the key to getting all of those difficult recommendations accepted, because my only contribution to that was to get delegates from the NGO community on government delegations through funding from the international community. That enabled the NGOs to sit at the negotiating table, where they were often able to contradict what the government said when they said, in our country, women want this, when they knew full well that they didn't, or didn't want this. And the NGO delegate would say, but in the same country, I know that women want this. And I think that really set the stage for all the agreements that were reached at the ICPD. So I want to thank SEDPA and all of your alumni and who continue to do this, and to thank you for all the things that you have already done. Today at the United Nations, during the current session of the General Assembly, we can see the consensus of the ICPD reflected in many, many documents that have come out since the ICPD. For example, the Millennium Development Goals, which were agreed by governments in the year 2000, most of them came directly from the ICPD program of action. But the key goal of the ICPD was, ironically, not included, namely reproductive health and rights for all women was not included. And, that was the beginning of the battles that we are still fighting today for what we agreed at the ICPD, but which is constantly under attack, and which is why we still need so many champions and so many people to speak out still today. The Millennium Development Goals have gender equality, empowerment of women. They also have now, as one of the indicators, sexual and reproductive health and rights for all. This after a lot of discussion, but it's not a main Millennium Development Goals. But we know that many of the goals, in fact, I would say like 5 or 6 of the main goals, really depend on the women getting autonomy over their own sexual and reproductive health decisions. We can see some tangible results since the ICPD. For example, maternal mortality, which didn't move for a very long time, is down now by 40% compared with 1990. And family planning is reaching over 65% of the women who need and want it. Many countries have achieved or will achieve parity in girls' and boys' education by 2015. Countries in all parts of the world are seeing more women in all areas of national life. Women are prominent in the regeneration we are calling the Arab Spring. But as you can see, and I hope that they will have an equal part in the coming Arab years and decades, but you can already see that in the commissions and committees that have been formed, for example, in Egypt, women are missing. So you can see progress, but you still see many of the same things still happening. So the progress is quite patchy. Among the economic leaders today are the countries that invested in women's education and reproductive health and family planning early on in their existence. But many countries, as Carol said, especially the poorest, and the poorest women in all of the developing countries lag far behind. Women's literacy rates are still much lower than men's. Pregnancy and childbirth still remain major health risks. And indeed, as many of you know, maternal mortality is the single biggest differential between developed and developing countries. I think that measures more than anything else the level of development of a country. And the Millennium Development Goal of reducing maternal mortality by 75% is still really quite far away. Unmet demand for family planning, as Carol just said, is enormous and rising rapidly because populations are increasing all around the world. UNFPA estimates that demand will double between 2000 and 2030, and there are already 200 million women who would use family planning if they could. And by if they could is if they had access and if they were enabled to use them, because they say they want them, but they are unable to access them. And it's not just physical access, but it's also the value system and the cultural and the other considerations that we need to address. And one can even say that for the poorest women in poor countries, the situation maybe hasn't changed much at all. And maybe it still remains what it was in their mother's lifetime. Poor women now, in my present work, I see, are also most at risk for HIV and AIDS, which remains a major threat to world health. The good news is there is that awareness and action on HIV and AIDS, and that action has increased tremendously. There is a lot of focus on the needs of women in HIV, and of course this is also linked to reproductive health and rights, and of course family planning. 2 US initiatives, PEPFAR, the President's Emergency Fund for AIDS Relief, and the Global Fund for AIDS, TB, and Malaria, have spearheaded an enormous increase in resources for HIV and AIDS, and also for TB and malaria. But I think the good news as far as this funding for the HIV/AIDS is concerned is that they have started to realize that unless they also link themselves with reproductive health and sexual health and family planning programs, they are less likely to succeed, and that they could have enormous savings if they could link the two programs. And of course, the family planning and the reproductive health programs, which at the moment seem to serve exclusively married women, need to open up to embrace all the population that needs these services, and not just married women, as it seems to be now still in a large number of countries. When I started my work as the Special Envoy on AIDS in Asia and the Pacific about 7 years ago, only Thailand had an HIV/AIDS policy and program. Now every Asian country has one. In those days, most countries were unwilling to recognize the rights of people living with HIV and AIDS, and those at most risk for the disease. The highly vulnerable groups, including married HIV-positive women, were ignored, and they were indeed stigmatized. And though the women got the infection mostly from their spouses, they were often the one blamed for the infection in that household. And terrible things happened to these women, and there are many cases documented, for example, in India, of women being thrown out of the household, thrown out of the village, burnt, beaten to death, etc. Happily, that is changing as the press and the media is bringing more attention to the plight of girls and women. But the goal of 100% coverage in preventing mother-to-child transmission is looking realistic today, which was only at 50% a few years ago. It's really looking very promising today, and I think that's a good thing. But there is bad news here too. There are enormous gaps in HIV prevention coverage in the worst affected countries, and a crucial lack of care in almost all countries. Some of the groups most at risk, young people, for example, are the least likely to be covered with services and even less likely to have access to good education, good sex education. Young women are terribly uninformed or ill-informed about HIV and AIDS. The results are horrifying. 75% of new infections in Africa, for example, are among young women 15 to 24. And in the Asian region, it's young married women who are getting HIV and AIDS, and marriage is supposed to protect you. In the case of young married women, now it's being said that it is hazardous to your health if you get married. There is a common factor in the bad news, lack of attention not only to women's needs, but to women's power to change their circumstances if they are given the opportunity. In all countries still, in spite of all the rhetoric of the ICPD and the rhetoric of the world community and the rhetoric of the donors saying they want to support women's rights and women's health, women find little support for all the things they really do. In the poorest countries, in addition, women are likely to be malnourished and anemic still, and at high risk of complications and infections in childbirth. They are pregnant more often than they would like, as we know from the figures and the surveys. Married and unmarried alike, women are exposed to HIV and AIDS. And women are not only vulnerable themselves, they care for those who are already sick. All of these things drain women's strength and initiative. Sexual and reproductive health services and information are almost all targeted at women, even though now there are some attempts to reach out beyond women. But they exclude some critical groups, which I've already mentioned. For example, women without children, including young married women. In many societies, unmarried women are not supposed to have sex. Or if they do, they are apparently supposed to take the consequences in the form of unwanted pregnancy or infection. I think I'm exaggerating that, but of course that's the outcome of women not having any information about their sexuality and not having access to the means to protect themselves. Marriage, as I said earlier, is assumed to protect young women and men from these risks, but it does not. And in many cases, as I've said in the case of Asian women, it's quite the opposite. Special services for young people can fill part of the need, but what every country needs are integrated sexual and reproductive health services, including family planning. And I keep emphasizing including family planning because the family planning part of the program seems to have gone to sleep. It's not very visible, and even though that's something that such a large number of women in the world desire and want, as the surveys show, they are not very visible in the services that are provided. we should consider the needs of women both before and after marriage, with and without children, and all the other excluded groups, including perhaps men as well, and perhaps especially men. Men surely must have an equal interest in sexual and reproductive health and in family planning, but few programs fully address their needs and their responsibilities. And what does it all imply for the world community, but especially for the United States, since we are here in this country? In the first place, the United States has historically been the leader and the champion of individual human rights. All women everywhere have the right to choose when and whether they will be married, who they will marry, if they will become pregnant, when they will become pregnant, and the right to safe childbirth as part of their human right to health in general. This was the message of the ICPD, and this message had as one of his champions the United States, which made the ICPD so successful. And the United States played a leadership role in mobilizing resources for the implementation of that program. And indeed, if you go back to history, you will see that the United States was really responsible for the creation of the UN Population Fund. And in the beginning, it matched every dollar that any other country gave. It was only later that we, expanded and had a large number, and the US contribution declined. I think they understand that women have the right to education and the confidence which makes them confident to make their own decisions. They need enforceable guarantees for their rights. In 2 words, they need empowerment and equality. And the key to women's empowerment is autonomy and control over their own reproductive and fertility decisions. That's my firm belief, not now, from many, many years of working in the field, and I say this repeatedly. Of course, it is always easier to agree on these things than to bring them about, but I am happy to see that we have all these champions that I hope will indeed have great success in their own environment, in their own countries, and will make things go more rapidly. What policies makers everywhere have to understand is that women's empowerment, gender equality, access to reproductive health services, including family planning, is the only solution not only to women's issues, but to many of our other developmental problems as well. That's why the ICPD was population and development. One of the greatest global challenges is the high rate of population growth in some of the poorest parts of the world. As you know, this is the year of the 7 billion, and the UN estimates that the 7 billion will be reached in sometime in October. Who knows when? We may already have 7 billion. We have added 1 billion people in this century, and we will add another 1 billion people by the year 2025. More than half, the better half, will be female. We must support their human rights, their rights to all of the things that we have underlined, so that they can help solve our problem as well as their own. I think we have to get that message out, that the women are the key to development in every country of the world. And I really firmly believe this. Countries which progress have women and men contributing. You can't have a country where you only allow half the population to contribute to its welfare and development and half the population to be in bondage to the other half. Maybe I'm stating it a bit extremely, but the rhetoric sounds good, but in the content of the rhetoric is true. As always, the United Nations provides the essential forum for discussion and the mechanisms for action. And as always, the United States is the essential nation, as Madeleine Albright put it, to lead the debate, to build consensus in 1995 and move to action. you can see that where the U.S. has played a leadership role, I don't mean in financing necessarily, but I mean a leadership role in the sense of ideas and programs. I think we have leaped forward. But where it becomes a problem, as it has been in the recent past, and where policies have changed with changes in different governments, I think the world has really suffered, and I think the United States policies in the world have also suffered, in addition to the fact that many, many millions of women in the poorest countries of the world are getting affected by the decisions of the United States. I would say especially civil society groups, which depend on funding from international civil society groups. They are the ones who actually carry out many of the community-level programs and provide the services and lead the discussion on what are the things that make social change happen. I think that's a serious, serious outcome of this lack of leadership on the part of the United States. United States leadership does not imply that the U.S. has all the answers. One of the most useful things that any donor can do is to listen. In this case, listen closely to what women have to tell them. What women have to say may be somewhat different from what you will hear from their governments or from men in leadership positions. It is the task of the international community and civil society to thread that needle, to help women find the path towards empowerment and equality in their own context. And again, I want to emphasize that access to sexual, reproductive health and family planning is an important, if not an essential, part of that path to empowerment. This inevitably involves partnerships with the governments and with men in general, as policymakers, employers, colleagues, family members, friends. How those partnerships work is for women themselves to find out, with encouragement and support from the international community and from the United States in particular. But I believe that there are many male champions, and we must cultivate them as well, because we need also male champions to help to change the policy, because for obvious reasons, most of the policymakers are men, and there are some who can be champions. The women of the world do rely on the United States to give an example of empowerment and equality and to lead the charge for women's human rights. UN CEDPA embody the strength and commitment of American women on these issues. Secretary of State Hillary Clinton is a wonderful leader, supporter, and an example. But she also has a lot of other things to do and a lot of other things on her plate. More than ever today, she needs your help and your support and your work. Girls and women in many settings are actively seeking their basic rights, including sexual and reproductive health and rights. They are their own best advocates. We must just provide them the platform. Programs designed to assist them are pushing at an open door, but many policies are makers are unwilling to go through that door. We need to push them. And there maybe we need some other champions. They cite cultural constraints and other forms of opposition, but the opposition is often really in their own minds and maybe in themselves. The task of all of us in the United States and in the world community and the UN is to seek out the bold and the fearless among policymakers and link them up with the many bold and fearless women out here and out there. Together, we can be an unstoppable force. Thank you.
Thank you very much, Nafis. That was very inspirational. I think we're all ready to march. Thank you for the reminders of of the progress made, of the challenges that remain. And for those of us from the United States, I think your challenge and reminder to us of our tradition of supporting human rights is one that we need to keep at the back of our mind and to invigorate our own selves for action. And thank you for your call to listen to the voices of women. And now we have, and I think you referred to them as the bold and the
Fearless.
the fearless, the bold and the fearless. And we now have the opportunity to listen to two of those bold and fearless voices. And I hope you all will now help me welcome Tigas Casa Milko, Health Communications Program Coordinator for PANOS, Ethiopia. PANOS is a Spanish NGO that promotes family planning and reproductive health through a variety of innovative women's programs in Ethiopia. So, Tigas?
Thank you, Carol, for the introduction. Good afternoon, ladies and gentlemen. My name is Tigist Kasa, a journalist by profession from Ethiopia, an ancient country in the Great Horn in East Africa. I work for PANOS Ethiopia, as Carol mentioned earlier, which is a part of PANOS Global Institute under the regional PANOS Eastern Africa. As you may know, that Ethiopia has a unique feature in terms of culture, language, lifestyle, and very uniquely in her calendar system, in which it is 2004 now, not 2011. The diversity of life was the nation and nationalities create strong harmony. Let me tell you a story of Galemo, an Ethiopian woman. Galemo doesn't know when she was born, but assumes she is around late 20s. Her husband is over 60. Of her 5 children, the girls are married. Sadly, she lost the other 2 while she was pregnant due to carrying heavy jerrycans on her back and walk long distance. She always thinks about her daughters when they get pregnant. Losing her fetus twice have left scar in her heart. Her tired face telling you that carrying 25 liters jerrycan of water on her back may not end unless miracles happen in the area. She left her home at 6 a.m. to fetch water from the pond. Now it's past midday, and she has only a few minutes to get home. Many women spend far more hours searching for water than that. Only the lucky ones get it. Galimo had been forced to walk much further than the nearby pond in order to find her 25 liters. Walking quickly, taking long strides on the road, head bent forward and back bowed slightly. Today, more than 1.5 million women who live in pastoral or nomad areas are heading the household and shouldering responsibilities. Borana, the place where my organization works to address the needs of these pastoral or nomad communities, is located in the semi-arid and semi-arid southern lowlands of Ethiopia. For many years, women like Galimo have struggled with life, climate change issues, and health issues as well. They move place to place to look for their foods for their family as well as for their livestock. They are really, really dependent on their livestock for their livelihood. The Borana pastoral community is made up of nearly 1 million people, and more than half of a million are women, according to the 2007 census. The workload for these women is really high. Walking long distance for women to fetch water and look for food is norm. Again, due to climate change problem, pastoral or nomad communities are more vulnerable. Their health status remains a huge challenge. The facilities for antenatal and postnatal care and services are not advanced or plentiful. There is one health post serving 5,000 people in one district. Thousands of women are giving birth in traditional ways with traditional birth attendants. That's why my organization started working on marginalized groups and issues in order to bring sustainable development. The areas where my organization engages are communication and information. If I am not mistaken, PANUSTEP is the only international organization working on information and communication, which is really difficult to address all major issues, especially for marginalized groups. The Ethiopian government has strong commitment to enhance the life of pastoral communities in Ethiopia. PANUSTEP also supports this commitment through different approaches in order to make a difference in pastoral or nomad communities. Microcredit is on our agenda to improve the lives of pastoral women in Borno. More than 50 women credit associations have formed to help out their livelihood and food security. When they gather to get their loans, we raised different reproductive health, family planning, gender-based violence, and particularly harmful traditional practices issues through organized gender forums. They also get trainings on life skills and saving. The issues of antenatal and postnatal care remain as a challenge. As a nomadic people, it would be difficult to provide movable health facilities, but if number of trained health extension workers are available, things might be changed. PANUSTEP delivers information to create awareness on these health issues. The microcredit agenda has also made significant achievement. All women credit associations report 100% returns on their loans. But reproductive health and family planning issues and facilities have not yet achieved as we expected. Of course, there are challenges of fund shift and work on environment and climate change issues, which is my organization supports firmly. But one way or another, integral work is needed to address the challenges of pastoral communities, especially women. The information and communication work is a key to create awareness of the pastoral community and sensitize the relevant stakeholders to make a difference. While I'm presenting this speech, Galimo and her pregnant daughter are trying to do remaining housework fast, so they still have time to fetch more water and also go to highlands to get cattle feed. If we want to reach Galimo and her daughter, we have to adapt our programmatic thinking like PANUSTEP is starting to do, and take into account the needs of nomadic women. When it's a choice between walking to get water and walking to get contraception, water will win. I would like to ask the United States government to consider marginalized communities due to geographical setting and related factors. This population, health, and environment integrated development should be enhanced. It's a holistic participatory development approach whereby issues of environment, health, and population are addressed in an integral manner for improved livelihoods and sustainable well-being of people and ecosystems. It will maintain community goodwill, trust, and increase pastoral women's status and self-perception in the area of family planning, reproductive health, harmful traditional practices, and women and children's health. Finally, I would like to thank Center for Development and Population Activities, CEDPA, for giving me this opportunity on behalf of the rest of participants from other 5 African countries. I would like also to thank David and Lucy Packard Foundation for sponsoring us to advance this agenda. Thank you.
Thank you very much, Tigges, for a very eloquent statement and a reminder of the complexity of working in hugely varied regions where the needs of populations and pastoralists and nomadic populations are very, very different. And I think your example, I will certainly remember that we need to work towards a world in which no woman has to decide between getting contraceptives and getting water. So that's something I think hope we can all remember that. Now traveling west across the continent, we will now hear from Rosemary Ardefio, and I'm probably mispronouncing everyone's names, and I apologize, but from Ghana. And Rosemary is the page editor for Graphic Communications Group, which has a newspaper that has pioneered health reporting in Ghana. And her newspaper devotes 3 pages each week to articles related to women's health issues, particularly reproductive health. So, Rosemary, we look forward to hearing from you.
Thank you very much, Carol. Good afternoon, everyone. Like Carol said in the introduction, my name is Rosemary Adefio. I'm a journalist from Ghana, and like she said, once again, my country is located in West Africa. It has a population of 25 million people. And I'm sure some of us know that we in Ghana pride ourselves, and we always say we were the first African country in sub-Saharan Africa to attain political independence. Ladies and gentlemen, I start by introducing you to a Ghanaian woman called Mary. Just like Tigi's story says, Mary is a 25-year-old Ghanaian woman who had to serve a 15-year jail term for killing her one-day-old baby boy. She delivered the baby alone at the back of her house, put it in a plastic bag, and dumped it behind a public bathhouse. Mary is a single mom of 3 children, fathered by 2 men. The father of the child she killed was also different. All 3 men had abandoned her. Mary was then a bread seller and made about 50 Ghana cedis, approximately $35 a month. When her 3rd partner abandoned her when she got pregnant, she felt she did not want the baby because she could not care for another mouth. And the terrible solution for her was to kill that child. Even now, I still remember the painful expression on Mary's face the day she was sentenced. Sad that she was being taken away from her children, then aged 7, 5, and 4. Mary walked out of jail 2 years ago, thankfully, but she's still trying to sort out the derailed lives of her children who were virtually left to fend for themselves, as the relatives who took over their care also lacked the means to adequately care for them. Ladies and gentlemen, I'm not implying that Ghanaian women normally kill their babies because they can't take care of them. However, Mary certainly represents numerous Ghanaian women in the reproductive age group who either do not want to have any more babies or want to space their beds but do not know how to do that. According to the Ghana Demographic and Health Survey, 35 out of every 100 Ghanaian women in the reproductive age bracket want to space or limit their beds, but yet are not using any modern family planning methods. The percentage of women in their reproductive age group using contraceptives also dropped, sadly, from 19% in 2003 to 17% in 2008. Somehow, Ghana has not given family planning the attention it deserves, although the health sector's protocols and guidelines stipulate that family planning services be provided as an integral part of reproductive health. Ghana, like many others, is a developing country that is grappling with competing issues of underdevelopment, including poverty, limited access to quality health care, lack of women empowerment, and cultural barriers which prevent women from exercising their reproductive rights. Consequently, Ghanaian women continue to die needlessly from preventable pregnancy-related causes. 350 Ghanaian women out of every 100,000 live births died due to pregnancy-related causes. These include bleeding, obstructed labor, infections, hypertensive conditions, and unsafe abortion. Ladies and gentlemen, my encounter with Mary as a young journalist was an eye-opener. Like a majority of the journalists in Ghana, I had limited my profession to reporting political issues, and nothing else mattered. Mary's story changed the course of my career. I felt that the story of Mary and that of the numerous Ghanaian women whose lives were being destroyed because of pregnancy-related causes must be heard. we had heard enough from the technocrats in the health sector. Since then, my crusading role has been to advocate for improved reproductive health for Ghanaian women, particularly family planning services. Luckily, I happened to write for a newspaper called the Daily Graphic, which is the largest circulating newspaper in Ghana, and therefore sets the agenda for national discourse. The other media, both private and public, therefore try to emulate the style of the paper. Hence, over the years, journalists from other media houses have also begun to focus on reproductive health issues in my country. Though this is an exciting development for people like me who many years ago were a lone voice, the increase in health journalists and health programs have still not achieved the desired impact of increased uptake of family planning services in Ghana. Many journalists still do not understand the issues well enough to discuss them rationally. We still have journalists covering health events and just reporting what the technocrats and politicians say, instead of looking out for the real stories of Ghanaian women. This situation, I believe, strongly must be addressed, because the stories of our women who are dying from pregnancy-related causes should continue to be told in a compelling manner till our government makes good the many international commitments it has signed to, such as the Millennium Development Goal. The myths and misconceptions that scare our women from using modern contraceptives must be dispelled. The facts behind the compelling evidence that improving family planning services will have a positive effect on the country's development should be laid bare. And our decision makers should be told again and again that it is time to scale up family planning. However, I know, and I'm sure most of us know, that the media cannot do this effectively alone if they are not well informed. It is my hope, therefore, that the U.S. government will consider supporting the training and retraining of Ghanaian health journalists who have emerged over the years, so that they will be both equipped to put out the right information both to the public and government officials. Finally, I would like to use this opportunity to thank the David and Lucy Packard Foundation for this opportunity to address you, which was made possible through my sponsorship to the Strengthening the Voices of Women Champions for Family Planning and Reproductive Health workshop organized by SECPA. Thank you very much for your attention.
Thank you very much, Rosemary. Again, I think it was incredibly important to hear, for us to have an opportunity to hear from you as a journalist, because I think you do bring very special ways in which we can deal with this issue and a new perspective to us. So thank you very much. I think you will see from our three panelists that we do indeed have three very special champions and bold and fearless champions. This is going to be my new mantra. And every woman a bold and fearless leader. But we'd like to now sort of open up the floor for questions, and I encourage you to take the opportunity to hear from our panelists or any of our participants in the front row as you think about questions. And I think we will remain seated during that part of the question and answer period. To say one other thing I probably should have said about the workshop, and I think it came through a bit with our two representatives, is Rosemary is a journalist and Tigist as an NGO representative. We also have members of parliament from Ghana. We have government representatives. We have a wonderful cross-section of people who care about reproductive health. And I think that is part of the message of advocacy, is to build those coalitions and to strengthen the combined voice of people. So again, with that, I'd like to open it up for anyone that has any questions. And if you would identify yourself and I'll give you a few minutes, or I'll give you a few seconds to think of a question. If not, I will think of one. So,
And you should add, we also have a male champion.
and we have a male champion here, yes, as well. I'm sorry, Usman. Yes, we do, and he really is an incredible champion, and his mother is an incredible champion as well. And so, do we have a microphone? We do.
Hand up.
Why, I think the first hand up was with the pink around your neck there. So could we start? Thank you.
Hi, my name is Nana. I am with the UN Foundation Global Health. I would like to thank you for your giving this opportunity. And my question goes to all of you. I am from DRC, and the issue of reproductive health affecting almost all African countries. Here we have women champion, as you call yourself, or as you said, but there is a lack of men champion. Now, what needs to be done is to include, instead of talking as a women issue or women health, it needs to be addressed as human rights health. Men need to be taking this issue seriously. So my question to the three of you is, what is being done to make men aware of this issue, for them also to be on the panel list discussing about this issue? Thank you very much.
Okay. Maybe we'll take two questions, and we'll let a gentleman speak for a moment, and while we think about the answer to that question.
Yeah, my name is Mehtab Karim. I'm on the faculty of George Mason University. It's rather unusual that we have only 3 or 4 men sitting along with about more than 100 women, and none on the panel, unfortunately. My question is from the panelists, and particularly our honorable keynote speaker, that we have seen that men have played a very important role in promotion of women's health in Europe or everywhere else, and more so in Asia. And wherever family planning has not succeeded, and Pakistan is one example where I'm originally from, that men have been completely ignored in the programs. And what I understand, the same thing is being done in this case, what I heard at least. And so I would repeat the same question which was asked by the previous person. Thank you very much.
Thank you. I think, I don't know how these mics work. Do they just come on automatically? Oh, they're on. Okay. Maybe I could ask Nafis, would you like to start, since there was a Pakistan reference there in the second question, about the what is being really done to help bring male champions to the table, and the importance of that, and to talk a bit about that. And then I would ask Tias and Rosemary to say the same about the experiences in your countries of things that you are doing, or some, perhaps even some obstacles you see to getting the male champions you need.
I think that programs are reaching out to men more and more, and there are many programs now, or I would say a large number or the greater number of programs that also address males and try to involve males in. Even in the Pakistan program, there was an attempt to, in the first program, to include religious leaders and to involve them in education and then in delivering the messages, etc. But, you know, it also ran, as you yourself very well know, into a political problems in it was seen as this, that, and the other. And, of course, the basic issue as far as male involvement is concerned, that through many generations and decades, men have controlled have wanted to exercise and continue to exercise over women's decisions within the family, and on all the behavioral aspects, including when they should marry, if they should marry, and the whole idea of family planning and so on, is a difficult issue for men to comprehend, and they wanted to have control, as you very well know. And I think that even in that climate of extreme conservatism and misuse of religion and culture, there are men who can be part of the solution. but we haven't involved them enough. And I think the programs need to go out actively and seek men partners and men leaders and men champions. I think that it can be done, and it's being done. I mean, for example, in Ghana, you have an excellent example of Dr. Fred Tsai, who is such a huge example. But in Ghana, for example, many women are against family planning. I found that the Secretary of Health in the Ministry of Health had all these very unusual ideas, I would say, about access to family planning, and that was a huge issue. I was quite taken aback because in my mind, I had always thought of Ghana as this progressive country in the image being created by Fred Tsai, but the reality is somewhat different in the country itself. So again, you have one male champion who's world-renowned, and in the case of myself, every country, every donor has always asked me this question: you had so much success in so many countries, what about your own? And I'm at a loss to answer that question because I know that we're not very successful. And it's not for the fact that Pakistans don't, generally countries are not necessarily proud of their nationals. But in the case of Pakistan, I don't say that. I think they give me all the honor and everything else, but they don't give me the honor of listening to me. And that's, it's a huge issue. I mean, I remember one instance in the Secretary of Women's Affairs was all for all these punishments for women and denying them their inheritance, because even though religion allows inheritance, even though it's half the proportion as for a man, but he was very against, land holdings going to women. I mean, he said, but you can't give land away to another family, that meaning the husband of the girl. So, all kinds of ways are used to curb women's rights and to deny them their rights. I think we need to have the educated men to speak out, and we need to have young women to start to speak out. That's why the UN Foundation's question and their excellent program on Girl Up is very important, because you need to change the situation of girls. When they are future mothers, they teach the same thing to their daughter, to how to be subservient. So it's a vicious circle. And what breaks that circle of, ideas and perpetuating the same kind of behavior is something that everyone has been struggling with. If they knew the answer, wouldn't we immediately implement it? But we'll keep looking at the successful programs. There have been good political leadership, both male and female. And then, women have been educated and kept healthy, and then they have been able to ask for their own rights. I think, everyone is trying to find that key, and I think male involvement is one of the keys that needs to be pushed and addressed, and maybe that will unlock many of the obstacles we face in our own countries. And then this reverence for religious leaders who are in our country often fake, because they're not really very well educated. They carry all kinds of myths in and which are believed by the society. They give instructions which are believed by the society, and it doesn't lead us into the 21st century. It leads us to the, 6th century. We're going backwards. And so I'm not sure I'm answering the question, because I don't actually know the answer. Because if I knew the answer, wouldn't I have implemented it a long time ago? But I do know that you need to involve men. Otherwise, we're always speaking to a gathering of women. We all agree and clap amongst ourselves, and we don't make any further moves. So the world stage, in that sense, like international conferences where men come to the conference, is a good stage, because at least there you're talking to men. And when they respond, whether they mean it or not, they say the right things. And so perhaps we should try to use what they say more effectively within their own countries. So I think we should look for the messages that men have agreed to, and maybe try to use those. Because at the international meetings, most men say the right things, most governments. But when they go back to their countries, they do something quite the opposite. And we haven't captured the way of, holding them to what they say at the international forum. And maybe they have more ideas.
Thank you very much. Rosemary, since Fred Tsai was set out as an example of Ghana, do you have any further thoughts about men as champions and things we could do further on that front?
Thank you. Maybe I'll speak from my experience as a journalist and what we're doing. I know I don't really know the details of the family planning program in Ghana from the point of program managers, but I know there's an effort to use champions. The Planned Parenthood Association of Ghana has started this advocacy effort to use champions to project the issues of family planning. And I know there are men champions. I mean, I've met quite a few of them. Like you just said, some of them are head of religious organizations, both all the religions that we have. And I certainly hope that is a good beginning. And maybe when we hear them speak, the other men will take the cue and come on board. But among us journalists, we've done a few trainings, and then we've made the extra effort to get a lot of male journalists on our trainings, and particularly radio presenters, with the hope that when they go out and they speak on air and we hear the men journalists talking about family planning, I mean, to get other men involved in the issues, and men will sit up and listen to them because they hear a colleague man speaking on the issue. It's a beginning, and we hope that as time goes on, we'll see some improvement in men involvement in family planning in Ghana. Thank you.
Thank you. Tigis, do you have any thoughts from thinking on the special communities that the pastoralists that you've spoken about? Are there any thoughts you'd like to share about trying to get male champions?
Thank you. Actually, it's very difficult to say on the nomadic people. The men's involvement really weak, and it's very difficult to say on that. But the other programs at PANOS, we have this men involvement program in all other activities. We just mainstream the issue in all programs. We really initiate and encourage men to involve, to be a champions on reproductive health and family planning issues. Related to what Rosemary said earlier, like we have media interventions, and so we have conducted several trainings for men journalists to be champions on reproductive health and family planning issues, plus really to take the lead initiatives on all their radio programs or other TV programs or shows to really address the issue of family planning and reproductive health and other related issues, including HIV/AIDS. And we have really good champions on media and related areas. But when it comes to the nomadic area, really they are so reserved. Still, we are trying to work on them.
Okay, thank you very much. I did think that perhaps we should ask Usman if he might want to make another thought on this, since he is a male champion, and if he has any thoughts on things that he thinks we all should be trying to do. And he asked if he could speak in French, and Danielle will translate for us.
Okay. Thank Carol. My English is not good, donc I try in French to share with you Malian experience with male champion. Je vais parler de l'implication des hommes en tant que solution, partie de la solution. Ils sont impliqués comme relais. Et comme tel, ils font de la distribution à base communautaire, au même titre que les femmes. Ça, c'est depuis des années.
He wanted to explain, talk about a little bit about how male engagement's used at the community level in Mali, working through actually community health workers and male community health workers that also distribute family planning contraceptives.
Autre catégorie d'hommes assez influents, ce sont les leaders religieux. Et actuellement, il y a un travail qui est fait depuis des années où on a un réseau Islam, Population et Développement qui travaille aussi bien sur les questions de santé de la reproduction, notamment le positionnement du planning familial et en même temps sur les questions de VIH-Sida.
Another cadre or another area that of male engagement is around religious leaders, working through religious leaders at the different levels in Mali. They have formed a network, a religious leaders network, that have really been trained on repositioning family planning and development.
Et ce mouvement du réseau Islam et Population est un mouvement ouest-africain aujourd'hui, puisque il y a un réseau ouest-africain en matière de santé de la reproduction et VIH-Sida qui a même fait une caravane qui a parcouru pratiquement des pays de l'Afrique de l'Ouest avec l'appui financier de l'USAID et sur une initiative de Health Policy Initiative.
It's important to note that the Association of Religious Leaders or the Network of Religious Leaders is a West African initiative, and that it was actually the Family Planning Network followed a network of religious leaders around HIV/AIDS, which had actually, this was something that was funded by USAID under the HPI, Health Policy Initiative Project. They actually did a caravan going through Western Africa to raise awareness around HIV/AIDS. And so an offspring of that has been the Family Planning Network of Religious Leaders.
Un troisième et dernier levier, ça sont les jeunes et les adolescents sur lesquels ASDAP, CEDPA se sont appuyés et puisqu'ils sont le futur de demain. Et nous avons testé la faisabilité de l'approche d'utilisation des garçons et des filles pour la promotion de la santé et de la reproduction, juste après le Caire, avec l'appui financier de l'UNFPA. À l'époque, c'était la directrice exécutive, Dr Nafi Sadik.
Another important group that ASDAP, in collaboration with CEDPA, is working with and had worked with are the adolescents, youth, working with both boys and girls. They are the future. And through, at one point through UNFPA, Dr. Sadiq was funding for working with adolescents and peer educators.
Et la première promotion de pères éducateurs au Mali, qui date de 1995, ils sont aujourd'hui dans des positions de décideurs et nous les utilisons comme champions pour faire avancer un certain nombre d'agendas, y compris sur la question des mutilations génitales féminines.
The first group of really peer educators of 1995 are now the champions themselves, and they are actually working with them as champions not only in family planning but around female genital cutting.
Et je profite de l'occasion, puisque j'ai le micro, pour dire que c'est un grand plaisir pour moi de revoir une grande dame, Dr Nafi Sadik, et qui, grâce à son leadership et à sa vision partagée, a su monter un consensus autour de certaines questions aussi sensibles en 1994. Et vraiment, aujourd'hui est un grand jour pour moi puisque je retrouve une grande dame. Également, l'opportunité que CEDPA me donne à travers sa présidente d'assister à cette, je dirais, à ce panel et aussi encourager les champions et à faire vraiment bouger des montagnes à l'image de la présidente de l'ONG ASDAP. Elle a évoqué dans son speech qui travaille depuis 1982 sur la question du planning familial. Et déjà en 1985, elle avait commencé à impliquer des hommes au Mali. Pendant qu'on avait 1,2% de taux de prévalence contraceptive, CEDPA, ASDAP, à l'époque, CEDPA avec Mme Traoré, ont su relever le taux de prévalence à plus de 50% en zone rurale. Je vous remercie.
Okay, I don't think I have to translate the first part. I think people got that even in French. But what Osman was talking about was actually where ASDAP in 1982 with Fatimata Traore really brought family planning to the agenda in Mali. And by 1985, particularly through her community-based distribution program, really helped have an impact on family planning through Mali.
Thank you.
Moving mountains.
Thank you.
Merci, l'interprète.
Thank you. Okay. Thank you. Here, another question way at the back.
That lady in the white, she's been putting up a
Okay,
hand.
I'm sorry.
She's been putting up a hand.
Oh,
for a
she
long
had, where?
She's getting it now.
Oh, okay. Good.
Hello, I'm Ariana Rabindranath, formerly with Asia Society, and now, excuse me, I'm establishing a nonprofit organization to address discrimination and violence against girls and women in India. And my co-founder is a man, a young man, remarkable person. One of the first issues that we want to work on is female feticide and female infanticide. And as you probably know, the more that technology, ultrasound technology, is made available to women and families in India, the more they're able to select the gender of their child and often abort girl children. And the fear is that the more this technology is made available to lower class, this will just skyrocket into a more major issue. And this has already created a skewed sex ratio, which feeds into lots of other problems, including human trafficking, because there are not enough women for men to marry. So could you comment on how this issue can be addressed within the larger reproductive health and rights sphere? Thank you.
I don't think that there's any answer to that. I think in India, the UNFPA has sex selection abortion as one of its major programs. But as we were discussing with them and together, was sex selection is a symptom of the deeper problem, which is in fact gender inequality and the situation of women. And women choose to abort a female fetus because they themselves believe that I've heard many women say, I don't want to bring a daughter who's going to have the same life as mine. And so I think we have to work on issues together. It's one to try to eliminate, but it's not going to be that easy to eliminate. The government of India has a law against sex selection abortion, and doctors are meant to be punished. So doctors never tell the sex of the child, but when they come out of the examining room, they smile if it's a boy, and they frown if it's a girl. I mean, that's what I've been told. I haven't seen this. So, I mean, there are other ways of sort of conveying the information without actually saying it. So I think it's a very serious issue in several countries. There are 4 countries where, in fact, sex selection abortion takes place: India, China, Korea, and Thailand, some parts of Thailand. The UN did a study many years ago, and these studies were done by researchers in these countries themselves. And in all these countries, the whole underlying factor is that there's preference for boys. And I mean, we need to change that preference for boys to, an equal whatever acceptance of girls and boys. And, it's like a chicken and egg. It's everything. I mean, you can try to ban it, but you'll always have to have policing to ban it, so long as the technology is available. And so long as the situation of women remains what it is, many women don't want to have, or many parents don't want to have that girl. So I think it's a very difficult issue to actually tackle. I mean, everyone condemns it, and everyone knows it should be eliminated. But how to actually make it happen is the same as changing the situation of women in society, which is what we are all struggling with. I don't have an answer actually, but we know that this is a very important problem. So many articles have been written, but who do you condemn? I'm not sure. You can condemn all the women in the country, or all the parents in the country, but I'm not sure what you can do about it then.
Do either of you have anything to add on that? No. I think not.
Well, okay. It's a very serious issue, but
it's at the heart of culture and the boy preference.
Everyone is trying hard to do something about it, and educating people and telling the mothers that girl is as much an asset, but she doesn't actually believe it.
Right.
Hi. My name is Rashna Raoji, and I'm with USAID Washington. I have 2 questions. One is, in the last 40 years, we've made substantial gains in family planning, reproductive health. But the biggest problems we are now coming across is stagnant family planning rates in most countries in Africa and Asia. And what I'd like to hear from you, Dr. Sadiq, is what you think we should be doing, or what more we should need to do, and what we need to change, because the world is changing so fast and the needs are also rising. And from your perspective, working for the UN and working at different levels, what would you recommend to the donors here in Washington, plus at the country level? My other question is, I'm going to give you two questions. The second one is the resource environment is getting very tight, and things are becoming very, very difficult. And the achievements we've reached so far and the gains we've got, not just in family planning, but also in other health programs, how to protect that and how to continue building it at a time when things are really very difficult financially, and there are big constraints and the priorities are different. Thank you.
Should I answer?
That was directed
I
to you.
think that the family planning program really is a cause for concern, because I think in this the attention to sexual and reproductive health, we've somehow, reproductive health is meant to include family planning, but we are somehow missing the family planning. So my suggestion to UNFPA is that we should start using family planning again, which we used to use sexual and reproductive health, including family planning, to bring back the emphasis on the family planning part, and not just make it commodities, distribution program, but in fact a real program which addresses all aspects: education, counseling, services, but follow-up services. And then, like what our colleague from Ethiopia was saying, and others, is also to see how women can actually access those services. I think so much was written before the ICPD on the fact of African women having to walk, miles to collect water, to collect wood. So we need to, find a way to get them time in the day. One suggestion that's been now going around in the global health circles is how to provide a one-stop service for women. It's a lot of rhetoric on it, and it can easily be done. But we know that in now working in the HIV, I see this. They go one day for counseling and testing somewhere, then another day to get services, another day to get TB because they've been also linked with TB, then a fourth day to get vaccinations. No woman can afford that much time in a week to go to all these things. If she could go to one place and get all these services, it would save a lot of time and effort, and you'll get a lot more people. Also, in a sense, like in other programs, like the polio immunization or other immunization programs, when children come for that, if they haven't received other shots, shouldn't that be used if they come for the first time out to give them other shots? No, the programs are totally vertical. We don't want to dilute it with other whatever things. So I think what is now being said is how to rethink our own vertical program strategies, not to discontinue vertical programs, but to make them all synchronized with each other. We would save money. This also links to your second question, and do a lot more with the present resources that we have. I think we lose a lot of opportunity to save the time and and the exasperation of the patients we are trying to, or the people we are trying to get to, but also how much time and effort we waste, how much money and effort we waste in not integrating services. That doesn't mean that everyone must provide all these services, but if a woman goes to a clinic, she should be able to get several things done at one time, not have to go on different days to visit the same people for a different service. Why can't they be located in one place? I mean, these are just some simple things that could be done, both to save resources and to make many other programs linked so that the counseling and testing and advice and services could be given together. And I think the family planning programs would progress, and I think the health programs would benefit. And, there's so many panels and expert group meetings on this global health and global health systems. Not sure where they're going because they haven't yet come out with any simple suggestions. I mean, why can't we start, in my mind, simple mind is simple solutions with the things that we have at our disposal, and start with that and then build up to this magnificent program which will have everything eventually. But I think the resources thing is the real issue. There's a lot of money now. There's a lot of money, as you know, in HIV and AIDS. But this, I think, for the first time, they're not going to get such huge amounts. And I don't know, for the treatment program, they need 12 billion. They'll only have 10 billion. So all these programs are going to be suffering. But on the other hand, there is money from a variety of sources for the global health for women and children, which is mainly maternal and child health, including family planning. I keep saying to the Secretary General and to all his staff that we should use the word also family planning and reproductive health in those, not just maternal mortality reduction, because without the family planning part, you're not going to be a full maternal mortality reduction program. I mean, if women had less pregnancies, by consequence, they would have less deaths. But, I mean, these simple things are not being done. So somehow we are not using our best common sense to do many things together, which would reduce costs and increase effectiveness, reduce the time burden on the person that we are trying to help and serve, and also be much more efficient and effective. We could have very good programs because they will deal with so many different aspects all at the same time. Makes sense to me, and I'm sure to many others, but somehow we are not able to implement it. There are many problems, I think, because we have all these vested interests, staff and institutions, and, they're all sort of guarding their own territory. Happens at the international level, certainly happens at the local level. So I think that integration and that new approach has to be built into the mind of all the donors, but also at the other end, the policymakers, and then at the local levels by the people who provide the services. I mean, it's a long answer, but I think there are many solutions that can be actually implemented very practically, very quickly.
Yeah, I think that's really very wise counsel to come up with some common sense solutions that can be implemented. I don't know if either of you're preparing advocacy action plans as part of the workshop. Do either one of you, your country teams, have the magical common sense approach that you want to reveal to us now? Not yet? Oh no, Tigas does maybe.
No, let me add on the question. When you see in our country, I think the major problem is it's a priority. The priority issues are critical. You can see all programs, especially on health, it's really revealed for you that they really consider uncommunicable diseases like HIV, AIDS, malaria, and TB. And what about the reproductive health and family planning issues? It's very difficult to see it as a prior level. So I think that's the gap. And the other thing is the integration.
What question? The what, sorry?
Integration
question.
Yeah, you can see the problems. HIV, AIDS, or malaria all really link with reproductive health. So I think that's the gap, and nobody considered the reproductive health and family planning issues. The other major things what I realized in my country is the fund shift. Most of NGOs really wants to convert their interest into environment and climate change. So, the health issues really remain as a challenge. I think that's really a gap what I really realized from my country.
No, the Prime Minister of Ethiopia is a big champion of the global program for women and health. He speaks at the UN very eloquently.
We'll check what he's doing. Other questions?
Hi, my name is Ariana. I'm a reporter with the Scripps Howard Foundation Wire here in Washington. And Nafis, you mentioned that the U.S. has a pretty integral role in a lot of these issues. I'm curious as to what specific policies, agencies, programs, areas of government, etc., are the most influential for better or for worse.
I'm not sure. What did I say? What policies? What
specific areas of the U.S. government, U.S. policies, etc., are the most important? You mentioned a few, but I was wondering if you had more examples.
I'm not quite sure whether I have any more examples. I mean, you mean of the U.S. leadership role?
Sure. What parts of the U.S. government are most important to try to provide the kind of leadership that...
Is Congress important?
Oh, yes. Congress is extremely important. U.S. aid is extremely important. But mainly, I think, the political leadership and the cabinet, because they say what is the policy of they speak of what is the policy of the U.S. government. So all these levels of the U.S. government, I can tell you, as far as the Cairo conference was concerned, I mean, from President Clinton and Hillary Clinton to Al Gore to Tim Wirth, they were all very, very supportive of the approaches, and each one did a lot. I mean, Gore by appearing, Hillary Clinton by doing many things at the NGO conferences. So I think they're all important, and there were many Congress people in the delegations. So I think all levels of the U.S. government is important, but mainly the policy is what makes everybody else function. So if the policies are correct, and Congress plays a very key role because they have these rules, the gag rule and this rule, and it's the way they apply them. The way they apply and interpret the rules keep changing as well. And they broaden the reach of that law, and then they reduce the reach. And then the president can make exceptions, so it depends on who the president is. So the laws also can get bypassed if you have the right president. So I'm not quite sure which one is the most important, but I would say the political leadership is the most important. And the U.S. as a whole is a very important player in the field.
Yeah, we were actually, just to mention that on the political note, we were talking earlier informally about some of the politics of the issues, and someone mentioning that 20 years ago in the Congress there were 60 Republicans who supported family planning, and today you can count them on one hand probably. And that kind of a difference, I mean, that makes a huge difference in terms of the political support. And how do we change the argument so people understand that family planning, in fact, is achieves the purpose of many of these people who say they're anti-family planning, that in fact if they knew the facts and really understood that family planning saves lives, that it prevents abortion, they would be more supportive. But how do we get the message across to people? I think there was something... Yeah.
Hello, everybody. Good evening. My name is Lillian Aju Aibe, and I'm originally from Nigeria. But I came here today all the way from Maryland. I am the president of We Refuse Incorporated organization. And We Refuse is actually an advocacy group against domestic violence for women. I was once a victim. Now, my question is, how do you incorporate, this is for Dr. Nafis Sadiq, as the UN Secretary General's special envoy, how do you incorporate domestic violence and regards to women sometimes, who are going through this, and the men try to force them or rape them, and they don't have no other means of trying to plan a family. There's a case of a woman who had a baby. She has 7 kids within 7.5 years. I don't know how she did it, but I believe it's rape issue and violence. So I'll be very happy to hear or to see certain, implementations made, or for these women to know what to do or where to go, as regards to the women's health. Thank you.
I think that the UNFPA has programs in all the regions on violence against women. It's been collaborating with UNIFEM before, and now it probably will do with the UN Women to strengthen these programs. Our first program on violence against women was started for Latin America, where there were all these, rape to make a girl marry you and, things like that. And then rape within violence, sexual violence within the household. But then rapidly, violence is an issue in all parts of the world for women. And so this program has been expanded, and it's an integral part of the programs that address the needs of women in sexual and reproductive health and rights. I'm not sure what the exact programs are now today because, I left UNFPA 10 years ago, but I know that this still remains a very important part of the programs. And in the whole concept of sexual and reproductive health and rights, violence against women is one of the things that is included. It was not included before in the programs that just pushed family planning, but violence against women was included. And the idea was, I remember we did a paper on this for UNFPA a long time ago, and that included also, violence within marriage in terms of rape and, not allowing women to use contraception, the whole notion of choice, that it should be broadened to enable and address the needs of women in all of these areas, many of which were hidden. Some are visible because they're visibly beaten or visibly raped or maybe not so visible, and including also like incest and within the household, and which is also very prevalent in all parts of the world, but which was always hidden. And the victim is often made the criminal if she, wants to report it or get some attention. It's like you're dishonoring the family. So all those issues were brought out in the open, and now they're being talked about in every region of the world. So it is happening, but I think, as attention goes up and wanes, that's what's happened, the whole issue of violence against women. I think we need to find a way where we sustain our attention to all these issues which affect, all aspects of women's lives, especially in the sexual and reproductive health area, and not sort of give one more attention than another and then forget about it after a while and go on to something else. I think the sustaining of attention strong implementation of programs is a very important part of really bringing about change. And I hope that many of the community leaders and leadership at the local levels will do a lot more on getting the voices of women heard. I think the press needs to do a lot more on getting the voices of women heard who have been subjected to violence. But, many women themselves don't come forward to, because they're embarrassed and ashamed or think that they're going to embarrass their family. So I somehow this has to be brought out into the open a lot more. I think that it's something we need to maybe discuss again in some depth, and just, an issue within this whole area of sexual and reproductive health and empowerment of women and women's rights.
Right. I don't know, Rosemary, whether you have, and certainly in your remarks, you spoke about some of the work that in the newspapers have done on that point. If you have anything to add on that, because I do think the violence against women newspaper coverage is an important way to change attitudes. If you had any further thoughts?
Yeah, I certainly think so. And from where I come from, the journalists in my country at one time had the opportunity to do a lot in this area because we had a strong coalition that just came out and they were pushing for the domestic violence bill at the time. And some of the journalists worked with them, and we finally got the bill passed. But some of our frustrations, particularly those of us in the media, is the lack of implementation of the bill. Mm-hmm. Because what's the issue if we do all the shouting and we get the legislation and nothing is being done? But then we still do try to still bring out the issues, because we have in the police force in my country, we have this unit we call DOPSU, Domestic Violence Units. It caters for, and we realize that most of the issues of domestic violence goes to that unit. Most of them do not end up in the courts. They are sort of settled at that level, and we in the media try to highlight those issues very much. I mean, in the hope that we get the issues out there, but we are certainly are praying for the implementation of the law.
Also, in many countries, there are lawyers who give advice, and legal counseling has become a big part of many programs.
Okay, I think we have time for one more. This would be our last question. Thank you.
Hi, I have a question to Jess and Rosemary. I'm Sarah Lindsay from the Aspen Institute. A big aspect of encouraging women to utilize family planning is getting the information, the knowledge, correct information, knowledge about services available to them. And since you both work in communications, I was wondering, what are some of the communication strategies that can be enacted to reach women who are most at risk or less likely to use services, rural and uneducated women, women who have low literacy rates, and how you're reaching them?
So did you get the question on communication, some of the best communications techniques and methodologies to reach women on the important on family planning services?
Thank you. Yes, we really are aware that one of the greatest barriers to the use of family planning is lack of communications. Like I said when I was presenting, in Ghana, we have the problem of myths and misconceptions. Women are not using family planning, even if they do have access, because they hear stories about side effects. They hear stories about the IUD will travel and get into your throat, and all sorts of things. And it's a great, great barrier, because we know that even if we create, we have all the supplies, we have access, and the women do not use the methods, we still will not have achieved what we want to do. So what we do as far as the media is concerned, and when I finish, I'll throw this question back to some of my colleagues in Ghana, and if they can add on to it. But what we want to do is we try to tell the success stories, the good stories, testimonials. I mean, we tell stories of satisfied users, satisfied clients. Sometimes when you hear, we put some of the satisfied users on air, on radio. When you hear them speak, the women can relate to them more than when they hear the technocrats speak. I mean, they live in the same community, and when you hear your next-door neighbor speak about how she was able to use family planning and was successful, and she's able to space her beds, and because of that, she's had quality life, they relate to that better. Okay, so that is what we do from the side of the media. If my colleagues from Ghana who are into programming and planning down there would want to add anything to it, maybe we could get some more information. Thank you.
That's it?
She's going to add something from the program fund, and I think...
Yeah, my name is Yasante. I work with the public sector.
We may just let one of you answer now, and that the rest can then discuss it in the reception, because we are starting to get close to the magic 5 o'clock hour when this room may close on us.
Like I said, my name is Yasante, and I work with the public sector. That is the Ghana Health Service, and specifically, I work in the family planning program. And one of the major components of the family planning program is IENC and BCC, that is Behavior Change Communication. And these activities are being done even in the public sector as well as in the private sector. What I mean is the public sector is doing its best, and also we have a lot of NGOs that are embarking on these activities to educate the public about the importance and the benefits of using family planning. And it involves the service, even at the service provider level, these useful information are provided to our clients in the media, like Rosemary mentioned. And we also have community therapists. Right now, as I'm speaking, we are having a family planning week celebration in Ghana. This is the first of its kind in our country. And we plan that it's going to be institutionalized. We're going to have it every year. And the idea is to educate the general public and also provide adequate information for policymakers so that they all come to know the importance of family planning as a development issue, so that they'll be able to push it and put it high in the national agenda and make sure that they provide adequate money for us to be able to buy family planning commodities. So in Ghana, I would say that as far as providing information for family planning is concerned, the public sector is doing its best, and also a lot of NGOs in the area of family planning are also doing their best. Thank you.
Did you want to just say very briefly? Okay. Thank you.
Thank you very much. I'm Nana Oforiwa-Assam, and I work for the Planned Parenthood Association of Ghana. In addition to what Ya said, we also use volunteers and peer educators. We train people. You know, your question was on those, you said the illiterates. Yes, so we use peer educators. So we train people in the community, and they in turn give the information to their friends in their own local dialects. And we also make good use of drama and role play. So they demonstrate it, and it's so informal, so that they get, they associate themselves with the various stories. So role plays and peer educators are the main means that we use to reach such community members. Thank you.
Thank you very much. Do you want to add?
I think it's forward the question to my colleague.
Oh, okay.
Okay, I'm Malcolm. I'm a technical person for Engender Health Ethiopia, and I have around 8 years experience on family planning, especially on reaching the rural communities. So to add on my colleagues' point, especially on addressing the information of the rulers or the illiterate women, the government of Ethiopia has launched a new strategy, that is the health extension program. Each health extension worker is assigned to serve a total of 5,000 households, and they are based at the health post, which is a lower level of the health system. We have the hospitals and health centers, and at the lower level we have the health post. So these health extension workers are expected to deliver around 16 packages, among others providing different information is the one, and they have also provided different short-acting family planning contraceptives. So using this health extension program, we have provided different informations on family planning, reproductive health. So if a woman is agreed to have like IUD or implant, they have counseled and referred to the nearest health center. So we use this strategy to address the communication need of this underserved populations. Thank you.
Well, I think, thank you all very, very much. Thank you for your excellent questions and for, I think, what was a very good conversation. And a special thanks to Dr. Sadiq, who came down from New York today to join us, and we very much appreciate that. And now what I'd like to do is to invite everyone to join us. We have a reception right outside, and we can continue some of the discussion in an informal basis, and I hope you can meet all of these wonderful women here who have wonderful stories to share with you. So thank you all very much.